If you are living with sciatica, diabetic neuropathy, or any kind of nerve pain, there is a good chance someone has already mentioned gabapentin or pregabalin to you. Maybe your doctor has prescribed one of them. Maybe you have been taking one for months. Or maybe you are considering starting and you want to know what you are actually getting into. These medications are among the most commonly prescribed drugs for nerve pain in adults over 60, and they do work. For some people, meaningfully so. But there is a great deal that most patients are never fully told about how they work, what the real risks are with long-term use, and most importantly, what your options are if they are not giving you the relief you were hoping for, or if you want to reduce your dependence on them over time. Today, I am going to give you the complete, honest picture, how effective these medications actually are, what the documented side effects are, how dosage works, and a thorough section on natural alternatives that the research genuinely supports. Because that is where I want to spend the most time today. This is not about telling you to stop your medication. That is a decision you make with your healthcare provider. This is about making sure you are fully informed and that you know every tool available to you. Before we begin, scroll down right now and leave a comment with your age and tell me, are you currently taking any medication for nerve pain? I read every single comment personally, and I genuinely want to know who is watching today. Let us start with the basics, because understanding what these drugs actually are changes how you think about taking them. Gabapentin and pregabalin are both classified as anticonvulsants, medications originally developed to treat epilepsy and seizures. Over time, researchers discovered they also reduce nerve pain signals, and they have since become one of the most widely prescribed treatments for neuropathic pain conditions. Gabapentin is sold under brand names including No.1. Pregabalin is sold as Lyrica. While they work through similar mechanisms, pregabalin is generally considered more potent and more predictably absorbed, which is why it is often prescribed when gabapentin has not provided sufficient relief. Both medications work by binding to specific calcium channels in your nerve cells, reducing the release of neurotransmitters that carry pain signals. In simpler terms, they quiet overactive nerve signaling. They do not treat the underlying cause of your nerve pain. They reduce the volume of the signal your brain receives. This distinction matters enormously, and we will come back to it when we talk about what you can do alongside or instead of these medications. Studies validated by medical authorities show that gabapentin and pregabalin can provide moderate to significant improvement in neuropathy symptoms, particularly in two conditions: sciatica, caused by a compressed nerve in the spine, and diabetic neuropathy, a complication of poorly controlled blood sugar. For these conditions, many patients report meaningful reductions in burning, tingling, and shooting pain. That is real, and it matters. However, the research also shows that results are far more modest for other types of nerve pain, including phantom limb pain, the pain experienced after amputation, and certain other neuropathic conditions. In those cases, the benefit may be minimal or inconsistent. The honest reality is this: these medications help some people significantly, help others moderately, and do not help others at all. Whether this tool works for you depends on the specific cause and nature of your nerve pain. Timing is also variable. Some patients notice relief within a few weeks. For others, it takes several months. This requires patience and close monitoring, because the same time frame that brings relief for one person may bring increasing side effects for another. The goal is always to find the dose that provides meaningful symptom relief with the fewest possible side effects. Dosing for these medications is not one size fits all, and it must be managed carefully, especially for adults over 60. For gabapentin, the maximum approved dose is 3,600 milligrams per day. However, clinical studies show that many patients experience meaningful relief at around 1,200 milligrams daily, well below the maximum. Your healthcare provider will typically start you low, around 300 milligrams, and increase gradually while monitoring your response. For pregabalin, doses typically range from 150 to 600 milligrams per day, again, titrated slowly upward. One consideration that rarely gets enough attention for older adults: kidney function. Both medications are cleared primarily through the kidneys. As kidney function naturally declines with age, these drugs can accumulate in the body at standard doses, amplifying both effects and side effects. If you are on either medication long-term, your kidney function should be checked regularly. Never adjust your dose on your own, and never stop either medication abruptly. Stopping suddenly can trigger withdrawal symptoms, including anxiety, insomnia, nausea, and in some cases, seizures. Any changes need to happen gradually under medical supervision. The side effects of these medications are real, well documented, and frequently underemphasized when the prescription is written. I want you to have the full picture. The most common side effects are drowsiness, dizziness, and fatigue. For adults over 60, these are not minor inconveniences. Drowsiness and dizziness significantly increase fall risk, and falls in older adults are one of the leading causes of serious injury, hospitalization, and loss of independence. If you feel unsteady on your feet after starting one of these medications, report that to your healthcare provider immediately. With long-term use, the concerns become more serious. Extended use has been linked to memory problems and cognitive decline, sometimes described as brain fog, difficulty finding words, or feeling mentally slower. For women over 60 already navigating the natural cognitive changes of aging, this is a meaningful risk to weigh carefully. Long-term use has also been associated with mood changes, including increased anxiety and depression, and with physical dependence, making it difficult to stop even when you want to. Perhaps the most serious risk, the interaction with opioid pain medications. When gabapentin or pregabalin is combined with opioids, the risk of respiratory depression increases significantly. In vulnerable patients, this combination can slow breathing to dangerous levels. Make sure every member of your care team knows every medication you are taking. I share this not to frighten you, but because you deserve the complete picture before deciding whether this medication is right for you. Now let us spend real time on what the research supports for managing nerve pain naturally, because this is where most patients are not getting nearly enough guidance. Let us start with vitamins, because specific B vitamins are not just supportive for nerve health, they are foundational to it. And deficiencies in these vitamins are extraordinarily common in adults over 60, particularly those managing diabetes or taking medications that deplete B12. Vitamin B1 thiamine is essential for nerve energy metabolism. Every nerve cell in your body depends on B1 to produce the energy it needs to function. Deficiency directly impairs nerve conduction and is strongly associated with peripheral neuropathy. The form called benfotiamine, a fat-soluble version of B1, is significantly more bioavailable for older adults and has shown meaningful results in clinical trials for diabetic neuropathy specifically. It crosses into nerve tissue far more effectively than standard thiamine. Vitamin B12 maintains the myelin sheath, the protective coating around your nerve fibers that allows them to transmit signals efficiently. When B12 is low, nerve conduction slows, and the familiar symptoms of tingling, numbness, and weakness follow. Up to 43% of adults over 60 have low or borderline B12 levels, often without knowing it. The most absorbable form for older adults is methylcobalamin, ideally taken as a sublingual tablet that dissolves under the tongue and bypasses the digestive absorption issues that become common with age. Vitamin B6 supports the production of neurotransmitters and plays a role in nerve repair. However, an important caution: too much B6 can actually cause neuropathy rather than relieve it. Stay within recommended therapeutic ranges and work with your healthcare provider. Alpha-lipoic acid, while not a B vitamin, is a powerful antioxidant that has been studied extensively for diabetic neuropathy. Multiple clinical trials have shown significant reductions in burning and tingling symptoms with consistent supplementation. It works by reducing oxidative stress in nerve tissue, which is one of the key drivers of neuropathic damage. Before starting any of these, I strongly recommend getting your B12 and B1 levels tested. Correcting a genuine deficiency often produces meaningful symptom improvement on its own, sometimes rivaling what medication achieves without the side effect profile. The second major natural approach is physical therapy, and I want to make the case for this more strongly than it is usually made because most patients treat it as optional when it should be considered essential. A qualified physical therapist who specializes in nerve pain can do something that no medication can: identify exactly which positions, movements, and postural habits are actively aggravating your nerve pain and teach you specifically how to change them. For sciatica in particular, the position of your spine during sitting, sleeping, bending, and lifting makes an enormous difference in how much pressure is placed on the affected nerve root. These positions are not generic. They depend on your specific anatomy and ideally on what your imaging shows. An MRI or X-ray of your lumbar spine tells your physical therapist exactly which direction your disc has herniated, which nerve root is compressed, and which movements will relieve versus increase that compression. Treatment built around your specific imaging is dramatically more effective than generic advice. Beyond posture and positioning, physical therapy uses manual techniques, hands-on work, to reduce muscle tension around the affected nerve, improve joint mobility in the spine, and restore the natural gliding movement of nerve tissue through the surrounding structures. Nerves need to be able to slide freely as you move. When scar tissue or inflammation restricts that movement, pain results. Nerve mobilization techniques gently restore that freedom of movement. Exercise prescribed by a physical therapist also directly stimulates blood flow to nerve tissue. Nerves require consistent oxygen and nutrient delivery to heal and to maintain healthy function. Even a structured walking program, gentle, consistent, progressing gradually, has been shown in research to improve neuropathy symptoms over time by improving peripheral circulation. If you have been managing nerve pain with medication alone and have not worked with a physical therapist, that is the single most impactful addition I would encourage you to consider. The third approach is topical pain relief, and while this will not treat the root cause, it can meaningfully reduce day-to-day symptom burden, particularly during flare-ups, without the systemic side effects of oral medication. The two most evidence-supported topical options for nerve pain are capsaicin and Arnica montana extract. Capsaicin, the active compound in chili peppers, works by depleting substance P, the neuropeptide responsible for carrying pain signals from your peripheral nerves to your brain. With repeated application, capsaicin progressively desensitizes the nerve endings, reducing the intensity of the pain signal over time. The key word is repeated. Capsaicin is a cumulative treatment, not an immediate fix. For the first few days of use, it may actually cause a temporary burning sensation as it depletes substance P. Many people stop at this point thinking it is making things worse. That is the most common mistake. If you continue applying it consistently 2 to 3 times daily, most people experience meaningful reduction in nerve pain by days 7 to 10, and that improvement continues to build. Arnica montana extract has well-documented anti-inflammatory properties and has been used in topical form for nerve and joint pain for generations. When applied directly to the area of discomfort, it reduces local inflammation and provides surface-level relief that can make daily life more manageable. Look for products that list capsaicin or arnica as the active ingredient, and avoid products with long lists of synthetic additives, artificial fragrances, or skin-sensitizing preservatives, which can irritate already compromised nerve tissue. Used consistently, topical options can reduce the overall pain burden enough to support a gradual reduction in oral medication, always under your healthcare provider's guidance. All of the natural approaches we have discussed are more effective when paired with one essential strategy, addressing the underlying cause of your nerve pain directly. If your neuropathy is caused by diabetic nerve damage, the single most powerful intervention available to you is blood sugar management. No vitamin, no medication, no therapy manages diabetic neuropathy as effectively as reducing the chronic high blood sugar that is actively damaging your nerves. Studies consistently show that well-controlled blood sugar not only slows the progression of diabetic neuropathy, but in some cases allows damaged nerves to begin recovering. This is not a supplement recommendation or a lifestyle suggestion. It is the foundation of effective diabetic neuropathy care. If your nerve pain is caused by sciatica, compression of the sciatic nerve in the lumbar spine, the structural issue causing that compression needs targeted attention. Medication manages the pain signal. Physical therapy, posture work, and in some cases medical intervention address the compression itself. Symptom management alone does not resolve the underlying problem. The goal is always to eliminate the source, not just quiet the signal. Whatever the cause, make sure treating it is part of your plan, not an afterthought. A few final safety reminders before we close. Never stop gabapentin or pregabalin abruptly. Both require a gradual taper under medical supervision. Never combine them with alcohol. The combination dramatically amplifies drowsiness and fall risk. Do not drive until you are fully confident about how the medication affects your alertness and coordination. And if you are taking any opioid medication alongside either of these drugs, ensure every doctor in your care team is aware of both. If the medication is not providing meaningful relief after a reasonable trial, typically 8 to 12 weeks at an appropriate dose, have an honest conversation with your healthcare provider about alternatives. Continuing indefinitely without clear benefit is not a neutral choice. The bottom line, gabapentin and pregabalin are legitimate tools for nerve pain. For some people, they are genuinely helpful, but they work best as part of a broader, holistic approach. one that includes targeted nutrition, movement, topical support, and most importantly, treatment of the underlying cause. The goal is always to need medication for the shortest time possible at the lowest effective dose, while your body does the deeper work of healing. You deserve to make this decision with full information. That is what today was about. If this video helped you, please hit subscribe and share it with someone managing nerve pain. It could genuinely change how they approach their care. And right now, drop a comment below with your age and tell me, are you currently taking any medication for nerve pain? I read every single comment personally, and I want to hear from you. I will see you in the next one.